Case study about amphetamine poisoning, presented by Zahra Diya Jassim. Indication: amphetamine is a CNS stimulant to cause hypertension, tachycardia with feeling of increased confidence, sociability, and energy. It suppresses appetite and fatigue and leads to insomnia following oral use. The effects usually start within minutes and last for many hours later. Users may feel irritable, restless, nausea, depressed, and lethargic. It increases the activity of the noradrenaline, dopamine, and neurotransmitters system. Mechanism of action: amphetamine is a CNS nervous system stimulant that functions by increasing the amount of dopamine, norepinephrine, and serotonin to a lesser extent in the synaptic cleft through a variety of mechanisms. Amphetamine enters the presynaptic axon terminal through diffusion or uptake. The monoamine transporters DAT, NET, and CERT. Once inside the presynaptic terminal, amphetamine increases the amount of monoamines as well as DAMV. Amphetamine also inhibits the metabolism of monoamine neurotransmitters by inhibiting monoamine oxide. At the same time, amphetamine stimulates the intracellular receptor TAAR1, which induces internalization or transport levels of DAT. The effect of TAAR1 on DAT may also extend to NET and CERT, although co-localization of TAAR1 with these two transporters has only been indirectly evidenced in studies thus far. The net result of the activity is increased efflux of dopamine into the synaptic cleft and reuptake inhibition in the synaptic cleft through DAT internalization and direct competition. Toxicity of amphetamine: due to their ability to produce a powerful euphoric effect, amphetamine are common drugs of abuse. All major drugs of abuse increase dopamine concentration in the mesolimbic pathway, but amphetamines, because of their direct effect on DAT and VMAT2, can increase dopamine concentration far beyond the concentration seen for natural rewarding stimulants. Chronic exposure to amphetamine, particularly methamphetamine, at recreation doses has shown to destroy dopaminergic terminal in the striatum through a variety of mechanisms, including oxidative stress and excitotoxicity. The resultant blunting of the physiological dopamine response can further potential abuse. Signs and symptoms of toxicity: common signs and symptoms of acute amphetamine intoxication include hypertension, tachycardia, tachypnea, hyperthermia, mydriasis, tremors, agitation, and psychosis. The presentation can be highly variable depending on the amphetamine analog used as well as the simultaneous uses of other substances. Dextromethamine and methamphetamine have a higher affinity for DAT, and intoxication can cause psychiatric disturbance, resembling a mini episode for any acute psychotic break. Other electric amphetamine analogs such as MDMA have a higher affinity for NET and CERT and are potentially more likely to cause hyperthermia, serotonin syndrome, and rhamnodemolysis. The risk of hyperthermia and rhamnodemolysis may become compounded by the association of MDMA use in the dance clubs. Management of toxicity: management of amphetamine intoxication generally involves the use of benzodiazepines and antipsychotics to control agitation and psychotic symptoms. Beta blocker can also help to control hypertension, tachycardia. Intravenous nitrates may be necessary in case of severe hypertension. Severely agitated patients may require paralysis and intubation, and hyperthermia is managed with ice bath and evaporation cooling technique. Case of amphetamine poisoning: a patient was attended to Dr. Otaki for serviceman aged 28 become tired after driving his car for 3 hours and still having a long way to go, decided to alleviate his fatigue. He dissolved the entire contents of a benzodrine inhaler in hot coffee and drank the mixture. 15 minutes later, he felt dizzy and had to lie down. He developed a severe headache extended from the occiput to the vertex, and noticed a tingling in the extremities and difficulty in controlling movement in the finger. He began to feel that he was floating on air. Half an hour later, he felt sick and made himself vomiting by digital stimulant. 2 hours after taking the amphetamine, he was brought to the casualty department of the West London Hospital. His blood pressure was found to be 16/19. Stomach was aspirated immediately, after which he felt a little better, but he still complained that his head was bursting. Examination on his CNS revealed nothing abnormal. There was no change in the fundus, and the heart was not clinically enlarged. 1 hour later, his blood pressure was found to be 180/110, and he had become very restless. Phenobarbital sodium 0.2 gram was given intramuscular hemorrhagically, but although he became quieter, his blood pressure continued to rise, reaching maximum of 200/125. Half an hour later, 3.5 hours after taking the drug, phenobarbital sodium was repeated twice more during the ensuing 8 hours, and at the end of this time his blood pressure had fallen to 14/5/18. He was discharged to a military hospital where he made an uneventful and complete recovery. His blood pressure there fell to 12/5/75 and remained at this level during his 2 days stay.